GLP-1 medications may be helping you lose weight, but are they stealing your strength? A new study shows a simple shift in your nutrition could help you keep your muscle. I'll break it down and show the tools that actually work when I guide patients through this process. I'm Dr. Tammy Penhollow, a spine and joint specialist at Precision Regenerative Medicine in Scottsdale, Arizona. Let's get started. These GLP-1 medications have been game changers. A huge percentage of the population have tried them, and they're losing amazing amounts of weight. I've talked about it before in a couple different videos, which we will link to in the show notes here. But really, let's break it down. Some of the things that are key that we're going to dive into a little bit more before I introduce this study, that an average of 40% of the weight lost is lean body mass. That is muscle, bone, water, connective tissue, not actually fat. But there are things we can do to try to combat that. And that's what this study also talks about, in addition to what we do in the clinic. Number two, that 2 years after starting therapy, up to 85% of people have stopped it. They've either achieved their weight goals, it's become too expensive. This is a real problem. It's a real risk, because the more muscle or lean body mass you lose, the higher you are at risk for diabetes, cardiovascular disease, and all-cause mortality, because you've got more fat in the tank than muscle in the tank. And that puts you at risk for all of these things. So let's do a little bit of the calculations. It's just going to make it easier. So if we're talking about what's healthy, let's take a 200-pound person, because it's just easier with numbers. What's healthy for a male is to have 90% lean mass, and that leaves 10% of the mass as fat. So in that person, there'd be 180 pounds of lean and 20 pounds of fat. Lean, bone, muscle, organs, water. In a female, healthy would be 80% of lean mass, and then we're looking at more like 20% of fat mass. So you could double those numbers with regard to that. Then let's break it down again. If you were 250 pounds and you wanted to get down to that 200 pounds, and let's make it easier on the male, that means a 50-pound weight loss. If you're going to take a GLP-1, and out of a June 2024 study from the Journal of Pharmacologic Therapeutics, showed that overall lean mass loss was 40 to 60%. They were in that higher, whereas a couple studies have showed as low as 15%. But let's just make it easy. Let's say 50% for calculation purposes of the weight loss was lean body mass. So that would mean of the 50 pounds that you were losing to become healthy at 200, that 25 pounds, 50% would be muscle, and 25 pounds would be fat. That is a lot. How can we prevent that? That's what we're going to talk about. Because look, versus if you only lose 15% of lean mass, and that's more of the goal. If you're using some of these strategies we're going to talk about, then you've lost 7.5 pounds of lean and 42.5 pounds of fat. I'd much rather have you lose 42.5 pounds of fat than just 25 pounds of fat when you see the difference of 50 pounds on the scale. So how do we do that? We do that with weight training. We do that with dietary changes. We do that with the M-Sculpt. But let's break it down. I said I was going to introduce to you a new study, and this new study is 2025. It is out of the journal Nutrition, and it is a 12-week pilot study. Pilot studies mean that it's an introduction, that it's getting started, that it's a small number of people, but if the impact is large or the numbers are large, then it begets a larger study. But here's what they did. They took 60 participants who were either overweight or obese. They are divided into two groups: a low-calorie diet group, where they did 50% carbs, 20% protein, and 30% fat, or a low-calorie ketogenic diet. I'll just call that keto. They had less than 30 grams a day of carbohydrates. It was 43% protein and 44% fat. Both diets provided approximately 1,200 kilocalories a day, Both groups were given equivalent doses of tirzepatide, one of the GLP-1 receptor agonists, for weight loss throughout the trial. They found that those who took the tirzepatide plus the keto diet, they preserved 95% of their fat-free mass. Pretty impressive. Versus 82% on the low-calorie diet. When total weight loss was broken down between fat loss and lean mass losses, it became apparent that in this low-calorie group, who was not keto, that the low-calorie group had lost a significant amount of lean body mass, and that their strength decreased, and that their resting metabolic rate decreased from baseline. That's a big deal, because remember, muscle is this thing that needs the fire stoked. The more muscle mass you have, the more you're going to take the calories that you intake, and you're going to burn them to preserve your muscle. But if you have lowered that set point, that means when you do stop the tirzepatide, that you've got that my metabolism is slowed down thing, and that you're more likely to regain the body weight. And in this case, because you've lost more muscle mass, you're going to regain that as fat. That's a big deal. So this study just kind of accentuates or punctuates the things that we've known for a long time. But in these 60 people, it was really eye-opening, saying, wow, maybe that ketogenic aspect can really protect things. I know a lot of people can't tolerate a keto diet, and a lot of people say that's way too much fat, and I don't want my cholesterol levels to raise, or I've already got high familial cholesterolemia, and that I'm at increased risk for cardiovascular disease as a result of that. I'm not saying keto's for everyone, but this is just a potentially different strategy for some people. What do I recommend in practice? Well, strength training is key, and we're talking about at least 3 sessions a week. And if you can do it in 3, that's perfect. And it's heavy weights. It's those where you have 1 or 2 in reserve, meaning that if we're going to set our goal at 12 reps, that you have put a high enough weight on that machine or in your arms if you're doing free weights, that you can get to maybe 14, but you stop at 12, because you know that your form would fail, or you'd literally drop the weight, or you would not be able to push that plate away from you if you're doing leg presses. And you're moving rapidly between the exercises. You are not taking breaks. You are not playing around. You are moving between. You can do the entire body in these sessions. It's not just, ooh, I'm doing leg day. Ooh, I'm doing back and bi. Ooh, I'm doing chest and tri. It's not that, because you need to move between all these, and that way you optimize things. You don't need to turn yourself into somebody who spends hours and hours and hours a week in the gym. You are doing this because you want to preserve lean muscle mass, because you don't want to be the people who, once you stop the drug, are at risk of gaining back only fat, and that fat then puts you at increased risk of diabetes, cardiovascular disease, and all-cause mortality. So weight training, heavy weight training, and regular weight training. Number 2, for those who can't get into the gym all the time, or they're starting from a place where they're so fragile, we use the M-Sculpt. In those 30-minute sessions, we do 20,000 perfect super maximal contractions. I don't know anybody who can do 20,000 crunches, 20,000 leg extensions, 20,000 calf raises, but we can do that with this machine, and it's done with me supervising it, so that we can, in 4 sessions of 30 minutes each, build that muscle and stabilize then the joints. Remember, when we lose muscle, we destabilize the spine, we destabilize the joints. So I've had so many people coming in who've lost all this amazing weight, but they're weaker. Now their back hurts even worse. And they're like, that doesn't make sense. I lost weight so that my back would feel better. I lost weight so that I could keep hiking. But guess what? I've got these little tiny toothpicks for legs now because I've lost so much muscle mass. That's what we're trying to combat. So the M-Sculpt, the resistance training, the dietary changes where you're eating a lot of protein, plenty of protein. We look at not that old, outdated RDA recommended daily allowance where you get 0.8 grams per kilogram of protein a day. In fact, let's just convert it to pounds. You should be getting at least 1 gram per pound a day of protein while you are losing weight, while you are lifting all these weights and doing the resistance training because you want to build muscle. You are in building phase. You are in anabolic building phase, not catabolic breakdown phase. And that's simply the facts. That's what you need. Some people would even say 1.2 to 1.5 grams per pound of protein a day, grams of protein per pound per day. That's just hard though, right? You are 100 pounds, you're eating 100 grams. You're 150 pounds, you're doing 150 grams. That's just at the maintenance of one, right? That's not at the building. If I say, let's go for 200, that's super hard to get. You can hardly eat that much protein. So I will be realistic and I'll say at least 1 gram of protein per pound per day when you are on these medications, because you do not want to lose the muscle. And actually, those are my recommendations, whether you're on these medications or not, because we want to decrease muscle loss, sarcopenia. That will decrease the risk actually of falls, of fractures, because with muscle loss goes bone loss, particularly with these drugs. So you do not want osteoporosis. Remember that 75% of all hip fractures occur in women. 25%, or 1 in 4, of those women who have a hip fracture in a year are going to die within the first year because of the all-cause mortality issues, the functional limitations of that, the mobility issues with that everything else goes downhill from there. So preserve the muscle, preserve the bone, lift the weights, eat the protein. In this case, we may want to increase the time that we're in a ketogenic diet from this study. It's interesting anyway, right? Then real world. I want to tell you about somebody who did this the right way, and I'm so excited for him. 260 pound, 59-year-old male, 260 pounds, 71 inches. He did it the right way. He knew that he had this craving. He tried losing weight on his own, but he said, look, I am pre-diabetic. My cholesterol is through the roof. I'm on a statin and it's kind of keeping it at this bay, but I don't want to be that guy. I'm getting ready. I'm aiming towards retirement. I want to be able to travel and go and do all these things. So he went from 260 pounds down to 208 pounds. He did it using a GLP-1 receptor agonist. He did it using 3 times in the gym a week at about an hour per time, and he actually built muscle during this time frame. There's no way that this guy has sarcopenia at this point. He is one of the most rippled, well-muscled people that I've seen, and he did it right. He came up on a low dose. He started at, in terms of units, I didn't do this. He has somebody that is guiding him on his GLP-1 receptor agonist. He went from 15 to 30 to 45 to 60 to 90. He met his goal. He started backing down, 75 to 60 to 45. Found that once he tried to go down below these 45 units for his doses per week, he's starting to get those cravings again, and he was starting to overeat. So he's maintaining at 45 units per week intramuscular for him. He is continuing to go into the gym. He is continuing to eat anti-inflammatory. He came to see me because he has a significant rotator cuff tear. There's one muscle that is a complex partial tear, and we're going to address it with his own cells, his platelet-rich plasma. But he's done this the right way because we've got increased muscle mass around the area that are stabilizing this joint. He actually was not positive for the traditional testing for this muscle because his other muscles are compensating, but he is in pain and he is weak, and he does have the tears that are demonstrated when we put him through that range of motion with the ultrasound probe on, and that's where we can see the tear, and it absolutely corresponds to what he cannot do in the gym. He cannot do those closed arms things. He cannot dip. He cannot lift above the head. These are all very specific things that he has done to make himself an excellent candidate for using his own therapy. So that's just an example of real world where you've done the anti-inflammatory eating, the high protein eating, the significant resistance training, and you've not lost muscle mass. In fact, you've built muscle mass. So that's made you stronger, made you more resistant. Oh, by the way, he's now off of the statin. Oh, by the way, his hemoglobin A1C is now 5.1, no longer a pre-diabetic. So done right, whatever combination of things, and it's not just one thing, you can be on the GLP-1 receptor agonist. You can lose significant fat weight and preserve lean body weight, and you can decrease your risk for all these other things: neurocognitive, diabetes, cardiovascular, osteoporosis, sarcopenia. Congratulations to all of those who are making this big change. If you have any questions or would like some assistance with this, please like, subscribe, ask any questions you have down below. I will link to the specific study that talked about keto. I'm also going to link to the other 2 videos that I've already done on this topic, and I look forward to seeing you next time.
If you have knee pain and would like to learn more, I have a worksheet called 5 Things to Do Now to Reduce Your Knee Pain Within a Week. Go to www.kneeboostnow.com to download it for free. I'd love to hear from you, so please like, subscribe, and comment below so I can help you get out of your knee pain.